This meeting is now being recorded.
And so we're going to record this meeting as well, so it will be available to you guys, usually available within a day or two after it's completed. So I also have in the room to me to the right.
Hello, it's Nick Roth, your WWC Data Coordinator.
And on my left.
Hi, this is Chris McCracken, Program Coordinator.
So Nick and I are going to talk together about some specific clinical case studies. Some of them are more frequent than others, and some of them are more rare cases. And so we're going to go through just kind of the basics of what you need to know clinically. This call really is focused on eCaST data entry, but we also want to make sure that if you have questions, be sure to ask them during the call. You don't have to wait till the end. We would like this to be more of a discussion. So let's get started. These are the case studies that we're going to touch on. This doesn't mean that at the end some other ones might come up that you want us to walk through with you, and we're happy to do that as well. So we're going to talk about how do you enter an initial mammogram, clinical concordance, when there is a new cervical lesion, short-term follow-up, how do you enter clinical services patient versus care coordination, what happens with endometrial biopsies when they're done with an AGC PAP and without, PAPs done sooner than recommended intervals, MRIs, second breast and cervical biopsies, and then also those referred in for diagnostic clients. All right, so we're going to talk about initial mammograms first. So this question gets brought up a lot, specifically when a patient has an abnormal CBE and goes directly to a diagnostic mammogram. Do we need, I don't know if we need to explain anything more than that.
You know, I'm not sure. This one's pretty straightforward.
Okay, let's move on to eCaST then, I think. That's pretty basic.
All right. Our eCaST example for this one should already be up. Let's hope I haven't timed out. Oh, and I did. eCaST timing out does that quite often.
And you're going to have to change your password in 4 days, Nick.
That is correct. It is coming up pretty soon. I don't do that until the last day. That's just how I roll.
One of the big questions around this is the reimbursement rate. And so when a case ends being reimbursed at a B2 level following a diagnostic mammogram, people get confused because it is considered diagnostic and they want to get reimbursed at a B3 level. But because it's an initial mammogram, it's actually a B2 level reimbursement.
I don't know if I have the right example there.
This one probably is one. We're looking through, because these are all real cases, so we're looking through some ID numbers to choose one to walk through with you guys.
And just a reminder, we are in the training environment, so we do have a de-identified data set in front of us, so we're not looking at any real PHI. The cases in here are real. They're direct representations of stuff that you guys have entered. So we've got the benefit of using real data without having the personally identifying information.
Yep, this is one. So you'll see that it's being reimbursed at a B2, that she had a CBE that was suspicious, and she went straight to a diagnostic mammogram. You hit on that green arrow just to show that there's a diagnostic mammogram. And so we're just showing you that your initial mammogram can be entered as screening or diagnostic, and here you'll see that it's diagnostic, and then that reimburses at a B2 level. Any questions on entering initial mammograms and screening versus diagnostic mammograms? *6 to mute and unmute yourself. Okay, that was nice and straightforward.
All right.
We can move on to clinical concordance with breast cases. So this is a sample email or question that I get pretty frequently, and it's when a patient had only a diagnostic mammogram following an abnormal clinical breast exam. The clinician correlated the results and is not recommending any additional diagnostics at this time. So this client is not going to move forward with a repeat CBE or a diagnostic ultrasound. And the recommendation is to return to an annual screening mammography. Can you administratively close the case? And
we just looked at. Looks like it's
that case we just looked at kind of. No, because that was a diagnostic. Well, yeah, actually that would fit that would fit it too. So what's important to know about clinical concordance is that eCaST will not automatically close a case, a clinical cycle for payment when a CBE result is entered into eCaST as suspicious and only one mammogram has been completed with no other diagnostic procedures or a repeat CBE. An abnormal CBE, even with a mammogram result of a BI-RADS 1 or 2 finding, requires further investigation. So you will always get an error if it ends in a mammogram. WWC realizes that there are times when a woman with an abnormal CBE is sent for imaging and the radiologist chooses to only do a mammogram and not do an ultrasound. But that does not mean the case is concordant or complete. So if that is the case, what you'll want to do is email me, the nurse consultant, so that I can and you want to explain the case to me either via email or phone, and I can override it in eCaST so that it will pay out, usually at a B2. Clinical concordance is usually achieved by the ordering clinician comparing the findings of the CBE and ensuring that the abnormality is explained by the imaging, or repeating the CBE within 30 days and comparing that with the imaging result. And this is just a sample email. I go through reports on a monthly basis. And this is one of the more common errors that I find, and so I'm sure some of you have received a similar email that just talks about clinical concordance and what is the follow-up for this client. The only way to get rid of the error is to email me so that I can close the case for payment. This is the policy on what to do, or guidelines on what to do when an abnormal CBE ends at a mammogram. And this policy is basically what I just said, and it's located on our website as well. So I do have a sample on this one.
All right, let's check it out. 23795, yep. All right.
Oh, we're just going back to the same one, right?
Yep. I think I'd gone to the one while you were explaining the policy.
Oh, okay. Okay, so you can see the CBE was suspicious and ended in a BI-RADS 2 mammogram and following routine screening. So normally when you're initially looking at this case, it would have an error, but can they see that administrative override on the bottom there?
Yeah.
Okay, so you can see the box that I checked that says administrative override. We do hear some talking, so if you could *6 yourselves.
your echo.
Oh, is it my echo? It is my echo. What does that mean?
Let's do the mute all. Is that the same thing?
I don't know. *96. We're going to see if this works.
All guests have been muted. You can unmute your line by pressing *6.
Okay, you can unmute yourself if you have a question by pressing *6. And I don't hear myself echoing anymore, so hopefully this will work. So this would normally end up in an error, but you'll see in the lower right-hand corner of the monitor where it says Administrative Override, when that is clicked, it will end up paying out and turn green for you. So no more error after that.
So essentially we have a way by which eCaST can catch these instances and make sure that we are doing proper clinical concordance. And the best way to do that, as Angie said, is to send along that email to make sure that we're completing the case fully by touching base with Angie. So this one is a good example of how that occurs, and then you should notice once you do put the email in, there should be a note section generally where we'll note what had been discussed and what we're going to do as far as going to routine screening. The note section is very handy. If you have anything that you specifically want to send along to Angie, you can always click on this note section and click Add a New Record, and that'll allow you to then write in a comment and click Save. It's just a way to be able to put the comment in the case while you're in there before you send the email so that it's noted how you're going to approach this, and just a good place to know which cases you've done this approach with.
Okay, if you have any questions, *6. Any questions about clinical concordance? Okay.
Angie, I just had a question on back to that first example. Is that okay?
Sure.
Mm-hmm.
The initial mammogram?
Yeah. So let's say there's a CBA is done and the provider recommends a diagnostic. For us, it would cost more than just that first mammogram. So I'm wondering, between the 230 and the 280, why wouldn't you get paid at 280?
Do you want to answer that, or do you want me to answer it? So when we do the calculations and come up with a bundled payment system, we do calculate that in. And so there is a little bit of a buffer. And so over time, if you're taking your percentages of initial mammograms that are screening and initial mammograms that are diagnostic, it should even out. But we do what's called a weighted average to find out that cost between the 230 and the 280.
Oh, okay. Okay, that makes sense.
But yes, that is definitely a question that comes up frequently. So good question.
Okay, thanks.
Okay. So next we're going to talk about what happens when there is a new cervical lesion. Okay. So this was a question from I think about a month ago. A new WWC patient from today's clinic has a large polyp on her cervix that Dr. Smith wants to be removed. Is there any chance of getting that approved through WWC? She has a PAP and a positive HPV, but the doctor states it needs removed regardless of cytology results. So that should be a negative PAP. It should read she has a negative PAP and positive HPV. So will WWC reimburse for this? Yes, WWC will reimburse for a colposcopy or a polypectomy regardless of her PAP and HPV results for cervical lesions, for polyps, or for any other suspicious cervical findings determined by the provider. It's important to keep in mind that a normal PAP cannot be used as a diagnostic indicator for a suspicious cervical finding on a visual exam, so you always want to send these patients to colposcopy. So what if the same patient came in and had a negative PAP but a negative HPV? So she would be on every 5-year PAP intervals. And we know that pelvic exams are are optional in the WWC program, but she decided that she did want to have a pelvic exam. So the provider did a pelvic and felt something abnormal. They then inserted a speculum, and upon cervical visualization, a polyp or a lesion was noted. Would a REPAP be indicated and reimbursed by WWC? And the answer to this is yes. Even though it was prior to the 5-year interval, WWC will reimburse for a REPAP at that time, and then also for a colposcopy or a polypectomy if it's a polyp.
I have a question.
Yes.
This is Oshana from Peak Vista.
Hi,
So
Oshana.
Hi. So if she did get a pelvic exam and they found the lesion, could she skip the PAP and go straight to COPO? Or a polypectomy? She doesn't need a PAP though, right? Or does she need to have a PAP again?
Some providers will decide that she doesn't need a PAP, so it's really up to the provider. If they are pretty certain that it really is a polyp, they can just do a polypectomy and remove the polyp, and in that case, she wouldn't need a PAP. But this question does come up quite a bit, and I would say most providers actually will just REPAP since they're already there. I don't know that we have any real guidelines from ASCCP on this. And I had talked with Dr. Shepard, our medical director, about this, and she would suggest just repapping anyone that has a new lesion.
And we would label that new cervical symptoms, right?
I'm sorry, what was that?
It would be labeled new cervical symptoms?
Yes, yeah, you can, yes, an eCaST, yep.
Thank you.
Yes, let's see if we have an example of that. Do we have one? Okay.
I'm not sure we have one at the time.
I don't know that I... We may not have an example for that one. Any other questions about new cervical lesions? So basically, don't be afraid to have your providers REPAP a patient if there's a new polyp or a new lesion. And anytime there's a new lesion on a cervix, you should definitely be sending this client to colposcopy.
So the next piece we're going to talk about is our short-term follow-up policy and guidance on how to enter short-term follow-up. And I'm going directly to our quick reference guide. And essentially the guidance on short-term follow-up is that if you're going to have a scheduled wait between a diagnostic set and then bringing the patient back in, that's when you would close out the first screening and diagnostic as short-term follow-up. And then when they come back in, whether it's at 3 months, 6 months, 12 months, then you would enter it as a short-term follow-up cycle after that fact. And we do have the guidance on the quick reference guide. It's a pretty frequent question we get. From what I've been seeing lately as far as tech assistance emails goes, you guys are doing wonderfully with the short-term follow-up questions, including the last Datapalooza. We didn't break out too many cases from screening and diagnostics into just screening and diagnostics and into short-term follow-up. So the general sense is that we've got a really good grasp on when to use short-term follow-up, but we did want to bring it up in the users group just to see if we had any questions in regard to the appropriate use of short-term follow-up in eCaST. Does anybody out there have any questions in regard to short-term follow-up?
How did you get to this document?
Where
do I find it?
This document, I believe, is listed in our training section. It should be on our...
the eCaST training section?
Yep.
All right.
It should be on our toolkit page, as well as it is posted on the YouTube short-term follow-up video. It should be in the comment section below.
Okay.
But if anybody wants a copy of the quick reference guide, by all means, shoot me an email, and I can send you one that you can have on your desktop and look at it at any time. So any questions on short-term follow-up at all?
Star 6.
Nick, this is Dee at Penrose.
Hey, Dee.
Hey, and I had one last week that was they'd recommended a short-term follow-up, and the patient did not, she didn't come back till over a year later for the follow-up. And
Okay.
so I actually talked to Angie about this one because I wasn't sure whether to put her in as a short-term follow-up because she was due for her annual mammogram anyway. So we did end up putting her in for her annual mammogram. We didn't put her in as a follow-up on that.
Absolutely agree with that.
It was over a year, so.
That's a very good point, Dee.
Okay.
And that's a great question too. Of if you're wondering how to handle things in eCaST, specifically data entry-wise, or what's clinically appropriate, the split on that is anything eCaST, you email me. Anything that you have in regard to clinical questions, you would email Angie.
Dee, I definitely remember this lady. I think it had been 14 months since she was supposed to do her short-term follow-up. And so, yeah, I think adding her on a new cycle was the right thing to do. But does WWC have a time period where that switches over from short-term follow-up to an annual? We don't. So I would just continue to say if any of you come up with similar issues in the future, just email Nick or I, and we will work on it on a one-to-one basis.
Okay, thanks.
Yes, you're welcome.
Any other questions on short-term follow-up?
I have.
Go ahead.
Sorry. I just wanted to make sure I was remembering this right. As far as with Angie, it was when we had the roadshow with the breast screening, and if the provider marks suspicious for cancer, but they have a mammogram and an ultrasound, they don't need short-term follow-up, correct?
Usually not. It depends on what the recommendation is, but usually not. They either need further diagnostics,
right,
or they can return to routine screening.
So let's say they had returned to routine screening, but the provider still wants to see them in 30 days. Do we close that out as a short-term follow-up and then start a new cycle when she comes in 30 days? Or
that gets kind of tricky because of eCaST doesn't always agree with what we need or what CDC is requesting from us. So if the provider or the radiologist is saying they want to see her back in 30 days, I would put her as a short-term follow-up.
Okay. Okay.
Any other questions on short-term follow-up at all, or if anybody would like a copy of the quick reference guide, by all means, please email me. I'm just going to get us set up for the next example, which is going to be an EMB after AGC.
So we know that WWC screens and diagnosis for breast and cervical cancer. When we have an atypical glandular cell PAP result, or AGC, you also sometimes will see it AGUS or AGUS PAP. We know that we're worried about. We're really worried about this client when there's an AGC result. And we need to move forward with a colposcopy and also an endometrial biopsy. In WWC, this is the only time we will pay for an endometrial biopsy following an AGC PAP. So we wanted to show you an example of that. Might be a different, is it a previous cycle? Because that's an ASCUS and not an AGUS. If you do enter an endometrial biopsy, on a, oh, there weren't any other cycles on her, huh?
No.
If you do enter an endometrial biopsy after a different kind of a PAP, even if it's a normal PAP or if it's an ASCUS PAP or a negative PAP with a positive HPV, it will give you an error, and we usually will just have you delete the endometrial biopsy entry. Can we switch that to Agus? Okay. We're going to do a little switch so that we can show you how this works. Okay, and then we can enter a new procedure, add a procedure, or add diagnostic, sorry. Endometrial biopsy.
There we are. Looking for the initial. Sure, I'm going to goof up the date on this. That's okay. Put it back a little ways. Just trim that.
And you just put negative or benign.
There we go.
Okay, so that's how you would enter the endometrial biopsy following an atypical glandular cell pap smear. Now we should have kept this back at Agus. Do you want to change that back to Agus and see if it gives us an error? ASCUS, sorry.
Sure. Let's see how smart eCaST might
Let's
be.
see how smart
if it is.
It should give us an error, ASCUS maybe, or, yeah.
Or it'll give us a procedure level error, maybe not. There you have it.
So now you can see that error that pops up, endometrial biopsy only covered after an AGC pap test. Any questions on endometrial biopsies in WWC? Okay. Okay. I think everybody's doing, I don't really want to spend a whole lot of time on this because everybody's doing such a great job now with screening intervals. We know that routine screening intervals for clients at average risk are every 3 years with cytology alone or every 5 years with co-testing with the PAP and HPV. So there are some instances when we will pay for a PAP done prior to intervals, routine intervals, and there are instances where we will not. So in this case, it looks like the client had a normal PAP history, and her last PAP smear was completed in March of 2012, and so she would be en route. She didn't have an HPV done at the time, and she would be due for another PAP smear or co-testing in March of 2015. Her PAP was done in February of 2015, March of 2014, and so what would happen in eCaST is if you entered this, it would show up that it was done too soon. And WWC would not be able to reimburse you for that PAP smear. So we're going to show you an example of this one. Again, this rarely happens anymore, but just occasionally so. And there are a lot of nuances. We don't really have a set grace period, So let's say that client, same client, cytology was done March of 2012, and she came in January of 2015. So she's 3 months early. I think our grace period is set in eCaST at 10 months. And so that pap smear also would come up with the error that it was done too soon. And so we do give you that 2-month grace period, but anything more than that would show up as an error.
Do I have the right ideas?
No.
Let's see.
Maybe it was the previous cycle.
Could have been.
No, well, no, I think it's the, yeah, view that one. Let's go into cervical and see. Oh, well, this is a good example of the abnormal cervical lesion. So we were thinking we were going to go in and see an error that this pap smear was done too soon, but that is not the case because this patient presented with an abnormal cervical lesion. So this is a good one for was it our second case studies?
We can create a too soon cycle.
Let's do that.
All right. We'll start this up first. We're just creating a cervical screening to demonstrate the pap interval being too soon. So I'm just setting up a new cycle for this individual.
It's defaulted.
Right, took the previous date for it. Funding source.
Right
There you
away.
So, you'll note that we have the PAP HPV performed sooner than medically indicated. The error should pop up as a procedure level error, meaning that when you enter it in the screening section of the eCaST patient accordion, it should immediately pop up as an error for you. That error will also show up on your screening errors table on your homepage. So this is what it looks like when you enter a PAP too soon in eCaST.
And so remember, we have in eCaST it set up as a 2-month grace period for that.
So if it was supposed to be 3 years, the 2-month grace period is about 34 months.
Yes.
34 months.
Yep.
Got it.
Want to move on? The next slide is basically we just got ahead of ourselves with the WWC case before. So there we go. So this one shows that the client who was early for her PAP, but it was because of a cervical abnormality. Okay. So we're going to move on to MRIs because those are always big questions too. So WWC will reimburse for a breast MRI when a client has BRCA or BRCA2 gene mutation. WWC will reimburse for an MRI if the client has a first-degree relative who is a carrier of a BRCA, if the patient has a lifetime breast cancer risk of 20 to 25% or greater, a history of breast cancer and has completed treatment for a previous breast cancer diagnosis, or has a result or concern on a mammogram that needs additional assessment. And I would say that the majority of cases that we see our agencies referring for MRIs is the latter, the last one, that there's a result or a concern on a mammogram, and they just want to take a little bit better look at it through a bilateral MRI. MRIs should not be used alone as a breast screening tool. It must be done in conjunction with a mammogram. And you'll want to just run the case by me through email or via phone and get pre-approval so that we can add a note in eCaST and overwrite it. Payment for an MRI is made on top of the BPS. So MRI reimbursement is not incorporated into the BPS charts. So we'll go through the first case here. This is a 46-year-old who came in for her annual Well Women exam. She had a normal CBE, didn't have any complaints or any changes in her breasts. She does have a family history that includes her mother having breast cancer at age 58. And her screening mammogram report included an area of concern, and so they wanted to refer her for an MRI. So in this case, WWC will approve this client for an MRI due to two different reasons: her family history of her mother being diagnosed at age 58, and then also the concern that was noted on the mammogram. We're going to bring up one of these sample patients for you.
Are you with this one here?
Yep. So you'll see right now that this is paying out at a B3, and so when you're looking at reimbursement in eCaST, it actually never shows the MRI reimbursement, and so that just shows up on your monthly bill run. And so you'll definitely want to let whoever your fiscal coordinator is or whoever it is that checks your the bill runs from us, make sure that the MRIs are on there. So they're additional payments to the BPS system. So we're just showing you this one so that you can see how it is correctly entered.
So what did you do to make it pay? Did you do an admin override or?
Sure. So most people will email me and say, okay, I need pre-approval. I will email them back. Yes, this client can have an MRI. And then what we do is we add a note to the note section. The note section is really handy because then it reminds me I can't override it until the actual result of the MRI is in. Mm-hmm. And so I've pre-approved it. I know that it's coming. I know this client's going to have it. I have a lot of staff will just email me again saying, hey, I entered the results on this MRI. Can you override it? And then that's officially when it gets paid out on the next month's bill run. So notes are really handy so that we can kind of keep track of these clients, particularly if it ends up being a couple months in between their mammograms and MRIs.
And one note on this case in the medical history is it looks like we're just missing a checkbox on the parent, sibling, or child with a history of breast cancer due to the history of her mother having cancer at 58. So just a note on making sure that we're checking those boxes appropriately. The notes section back. And this is what the data entry generally looks like. You can find the MRI in the diagnostics section. You would add it by clicking Add Diagnostics and then choosing that from your method, which is a little tricky. You do have to scroll down in it because the pop-up box doesn't display all of the options without a scroll, and it is toward the bottom. As Angie said, once you enter that, giving her a heads up and then letting her know once you've entered it. It's like adding any other diagnostic procedure in eCaST as far as data entry function. But it just lets you know that that is where it's located. It's a little hidden down below. So when you open up the box, it looks like this. And to get to it, you just have to scroll a little bit down.
So we'll just run through one more case study on an MRI referral. So this is a patient that was referred for an MRI due to unilateral dark right-sided nipple discharge since '09 and a history of a displaced breast implant. The report stated that a galactography would be slightly limited due to the new rounded asymmetry of the left breast, and they recommended an MRI for further evaluation of the right nipple discharge. So would WWC cover this procedure? Again, yes, we will cover it because it is a result or a concern on a mammogram that needs additional assessment.
Looks like we do have one more example. Let's go see what that second one looks like.
Any questions on MRIs while Nick is pulling up another example in eCaST? *6 to unmute yourselves.
This would be an example of the most recent question and answer that Angie ran through. And again, just entering the MRI is just like adding any other diagnostic procedure in eCaST, with the additional steps of making sure that you are contacting Angie about that procedure.
And those are my notes, just to remind myself that I approved it.
Good idea.
Very handy.
So this next example isn't actually about an MRI, it's about an ultrasound. So this was a question that came up a couple weeks ago. An agency had a patient that had completed her screening mammogram. She had a strong history of breast cancer. A mother was diagnosed at 64 and a maternal grandmother at 50. The screening mammogram result was BI-RADS2, and the recommendations included genetic counseling and risk evaluation, screening breast ultrasound of both breast, and screening mammography in 1 year. The question was, can I refer this patient for genetic counseling if she'd like to pursue that, or that she can refer the patient for genetic counseling, but I was wondering if WWC will cover the screening ultrasound. So currently WWC per CDC does not reimburse for genetic counseling or testing, and we received guidance 2 weeks ago that most likely this isn't going to happen, at least not anytime soon. So great if some of our agencies have other funding to pay for this, but WWC currently doesn't reimburse. And so we also would not reimburse for a breast ultrasound or an automated whole breast ultrasound when used as a screening method. And we did get further guidance from the CDC recently post the draft recommendations of the USPSTF guidelines earlier this month that this is not going to be a change either. They still do not recommend breast ultrasound as a screening method. Any questions on genetic counseling, or referrals or testing, or breast ultrasounds? *6 to unmute yourselves. can skip this next slide. Okay, so we're going to talk about second biopsies. So WWC has always paid for second cervical procedures or second cervical biopsies. But it's new that we have started paying for second breast biopsies. So I just want to talk a little bit more about those. I don't know if we have samples today.
I'm not sure we do.
Okay.
We could create one.
So I think just to save some time, since we have always reimbursed for second cervical biopsies, unless someone has a question about that, what we can do is just kind of move on to a second breast biopsy. Or maybe not, because we don't have a sample. I thought I had one here. So we may not be able to show you this in eCaST, because I don't know that we have an WWC ID to show you. But just know that now second breast biopsies are paid for. These are also are something that shows up on Datapalooza and our end-of-year reports. And so just know if you've entered that, I may, during Datapalooza time and end of year, I may be sending you an email just to confirm that indeed it was a second colposcopy. It was an excisional breast biopsy followed by a stereotactic breast biopsy.
We could potentially demo by changing these two diagnostics if you want to just do it.
Let's try it. Let's do it for breast though, because that usually, since it's a newer policy that we opened up.
Oops, hold on a second.
So, do they need pre-approval?
They don't need pre-approval for this. Nope.
And does eCaST just catch it? Or how do they get paid for it?
That is a good question. This is something that is similar to an MRI. I think it is paid on top of reimbursement. Yes, it is.
Right, it's an
Yep.
additional. I'm just going to change the diagnostics that are in here.
Okay.
And maybe we'll, what's the first one you would like?
You can do the stereotactic, the second one.
Result?
You can just do, insufficient sample was one.
Thank you.
And then add an excisional. You can just put any of those things. Yeah, okay, yeah, let's go with that.
I was looking for something.
Okay, so in this case, what happens is you don't need pre-approval for the second biopsies, but again, they do show up on my reports during Datapalooza and end of year, and I usually just come back and confirm with you via email that it was clinically appropriate to do the second biopsy.
And I think if I hit save here, this is going to bomb out with an awesome error in regard to
All this.
timing
All
of
of-
procedures.
Yeah.
Try it.
Let's see what happens.
What the heck?
Oh, just didn't
No, look
adjust
at that.
Oh.
Okay, so but you can see that it's just paying out as a B4, and with the second biopsies, you would have an additional payment for that second breast biopsy.
So how do they get paid for it? That's what I don't
Oh,
understand.
it's behind the scenes.
Behind the scenes.
Yes, and it's at Datapalooza and
that's
end
the
of
only
year.
time.
Yeah.
Okay.
Yep.
I see. Got it.
So we can skip through all those second cervical biopsy examples. Okay. So this is a question that comes up about quarterly, where you have a patient who has a different diagnosis unilaterally, and how should these results be entered into eCaST? And we needed to ask the CDC how they wanted this entered. And their response was that they wanted the procedures and the diagnostics all entered on one cycle, but that for their reporting purposes, they would like the most severe result reported. And so we do have an example of that as well. Or not. This doesn't look like the right one. 1, 2, 3, yeah. So again, this happens when you have two abnormal results on the same body part. This can get kind of complicated. So please don't hesitate to email me, myself, or Nick with these questions, and we can work through the best way to enter it into eCaST. Has anyone had this result, or anybody have any questions about this? *6 to unmute yourselves. Okay.
We are running a little low on time, so the next part we're going to talk about is referred in for diagnostics. We do get a lot of questions about this. Referring folks in for diagnostics in WWC doesn't mean the exact same thing that it typically means in the field. This is almost entirely tied to funding sources with screening procedures. So in eCaST, if you have an individual that comes in and they're having a screening paid for by a funding source other than WWC, and it results in an abnormality, you can then refer them in for diagnostics that will be covered by WWC. I'd just like to go into eCaST for a second and see if we can show one of these. And for the saving of time, I'm just going to go into what the patient accordion looks like, and we're going to manipulate a little bit of the data in there to demonstrate. This might be a bad one because it's CCG. Yeah, we'll check. So let's say that Komen covered the MAM and the CBE. Oops. Mouse, you're not helping me.
WWC.
Thank you.
It's hard.
So the place where you denote, and that disappeared, that's interesting. The place where you would note that you are going to do a referred in for diagnostic is in the MAM reason. And the date of the referral is going to be the date of the MAM performed. So in this case, it would be 4/1/2013. And what this does is it allows eCaST to know that the screenings are being paid for by another entity, but the diagnostics are going to be covered by WWC. And this is where you see the different BPS payments that are essentially a 3 or a 4 minus the 2 or the 1. To note that we're covering the diagnostics, but we're not paying for the screenings because we're covered by another entity. Chris?
Isn't that referral date the date of the diagnostic test rather than that mammogram?
I thought it was the date of the initial MAM.
Good question.
It is a good question.
I think it's the date of that initial mammogram.
So I believe it's the date that triggers the diagnostic follow-up required. So this would be your 4/1/2013. This is an old example. So when you put this in here and then follow the case all the way through diagnostics, and in the BPS it would come out as a 5 or a 6 as far as what your payment outcome would be. And that's essentially covering the diagnostics but not covering the screening, so it pays you the differential between either a 3 and a 4 and a 1 and a 2. Sorry, that's the very quick version of that. We do have a little bit of guidance on referring in for diagnostics in that quick reference guide. And the last thing we wanted to talk about just really quickly for you folks that have CCGP as well as clinical services is where exactly you can tell in eCaST which one is which. And the place where you know that you have an individual that's either going to be CCGP or going to be for clinical services is in the enrollment. And I'll show you the difference here. Essentially, you're going to have a CCGP patient if you have anything other than no private insurance or yes but high deductible. So if you have Medicaid, does not cover screenings, no private insurance, those would all qualify CCGP-wise. And if you're having no private insurance or Medicaid or yes to insurance but high deductible, those would go to the clinical services. And that's going to be your differences in payments between 1 through 6 are all for clinical services, and in BPS 7 and 8 are your CCGP payments. You can always see what the insurance type is in the individual in the enrollment. We did recently switch this so that it would display in this section as far as what insurance type we have. That's currently the only indicator in the record as far as the patient being either a CCGP client or a clinical services client. We are working on a better way to make sure that that's more clear for the users, but just quickly wanted to go over how you can tell if an individual is one or the other. So do we have any questions on that at all? I guess to open it up, do we have any questions on any of the topics we've covered today? If not, I'll use the remaining very short amount of time to do a totally shameless plug for June 3rd, 9:30 in the morning. I'll be doing a tech assistance webinar. It's the same login that you use for the eCaST users group, and it's a live open question and answer forum. I invite everybody who has a question to come and hang out, or if you just want to see what it's like to see what questions are being asked. In particular for newer users, I definitely recommend it. It's every other month, the first Wednesday of the month at 9:30 in the morning. It's in your WWC update. If you need information on that webinar, please feel free to email me. But we block out 2 hours, 9:30 to 11:30 Wednesday morning to go through specific cases. And we use the same training environment, which is an exact copy of the production environment, which is the real-time eCaST. We have our developers copy it just before the tech assistance webinar. So even if you were in there just before the webinar and had an issue with a client, we should be able to look at a de-identified version of that issue and then walk you through it. We can't fix things in real time there. We can only demonstrate. But I recommend it to anybody that has any eCaST questions. End of spiel, sorry.
And we hope to see some of you or many of you at the Wonder Woman Conference coming up June 10th through the 12th in Breckenridge.
And just to note, those tech assistance webinars, they are not required at all. They're there for your benefit if you have questions. I'll also be at the conference in a booth answering questions in regard to eCaST. So that'll be most of the day Thursday, so hope to see some folks and put some faces to names, and hope everybody travels safe for that one.
Any questions out there?
All right, folks, so we're going to stop the recording and just do a little roll call of the folks that we may have missed. So if we've already got you down, if you put your agency in the comments section, we've got you. But we're just going to go through the roll call and see if we missed anybody.
We'll let everybody who needs to hang up, go ahead and do that.